You could also treat mucoceles. You can do inflammatory pseudotumor. And then if you need just a tissue diagnosis, if you think the patient has amyloid or hemochromatosis, these approaches are very easy to get biopsies if you need to as well. The area where it's actually been very useful as of late are for things like meningoceles, people with spontaneous spinal fluid leaks, or encephaloceles, where in the old days you'd have to do that big bicoronal surgery, elevate the brain and put these barriers down to prevent the spinal fluid leaking. Nowadays we can repair almost all of those through the nose, and patients do very, very well with that. All right, well, although there's lots of stuff that we've been able to do now in the past decade or so through the nose, using that same technology, you can apply it to other parts of the brain. And one of the areas that we've been working on for the past 5 to 7 years now is the posterior fossa, so the back of the head where all the cranial nerves are in the brainstem. Why can't we use these same technologies to do less invasive surgeries back there? And so we've started to do that. When we first started doing it about 7 years ago, we actually thought we were brilliant with that idea, saying, wow, no one else is doing this, this is great. But then when you start to do a literature search, you realize that for the past 30 years, there have been people trying to use endoscopes in the back of the head. Before we had MRIs, in fact, ENTs and neurosurgeons were trying to play around with the early versions of endoscopes to look to see if people had acoustic neuromas because the current imaging they had wasn't good enough. So they would make these minimal openings, stick a scope in there to look to see if they found a tumor. One of the earlier endoscopes was a guy from a guy named Taka Fukushima. He called it the Cellfox scope, and he was one of the very first people to actually describe the imaging of the cranial nerves using an endoscope. So this is 30 years old right here of a guy who's using an endoscope in the back of the head to look at all the cranial nerves. He actually was an innovator in that sense. Unfortunately, he never really pursued it, and so no, it never really caught on at that time. But there are people that were trying it way back then. Now, in the back of the head, there are lots of different pathologies that you could also treat with an endoscope. Perhaps the two best are what are called trigeminal neuralgia and hemifacial spasm. But we've also used endoscopes for fourth ventricular tumors and acoustic neuromas, meningiomas, arachnoid cysts, and other tumors in the back of the head. When we do those surgeries, we do them exactly the same way we would if we were using a microscope. The patients are positioned the same way. We may or may not use a retractor depending on their anatomy. One thing that we absolutely do with these surgeries though is we use an endoscope holder. So when we're doing surgery in the back of the head, if it's for trigeminal neuralgia or for meningioma, lots of times we may not use ENT for those surgeries. We just have an endoscope holder. We don't need as much dynamic motion for those. For acoustic neuromas, we are using ENT, and we do that together as a team. But again, we would use an endoscope holder in those situations because we really don't want as much movement in the back of the brain as we have in the nose. This is basically the position that we'll use for these surgeries. We call it a lateral park bench. We strap the patients in pretty good because we really don't want them moving. And we usually are often rotating the bed quite a bit to allow us to get better angles to look at different areas of the brain. Once the patient is positioned, we do shave a small amount of hair just behind the ear. About an inch of hair is shaved. We then make an incision right behind the ear and then use the endoscope basically once we've opened the bone to start visualizing the posterior fossa. This is the typical size of our openings to get to the back of the brain. The opening is about an inch. The opening in the lining of the brain is about 2 centimeters. We tack it up with some sutures, and then basically we advance the endoscope through that hole. You get a beautiful image once you start advancing the endoscope. And the beauty of using the endoscope is we often don't need to use a retractor because the endoscope provides so much light in the wound, you don't need to retract a lot to get the light of the microscope in there. It gives you a larger field of view, so not only can you see the specific nerves of interest, but all the other nerves around it. You could use angled lenses, so if you're doing something like an acoustic neuroma and you're trying to find the facial nerve on the other side of the tumor, you can actually put a 45-degree lens in there and look around and find that facial nerve earlier than you would if you were using a microscope. And you're able to look out laterally very well, something that you can't do very well with a microscope. It does have some disadvantages, though. These endoscopes are two-dimensional, not three-dimensional. And the cranial nerves in the back of the head are not as giving as the nerves are in the front of the head. And sometimes just touching some of these nerves can cause a paralysis of the nerve or cause hearing loss, a facial numbness. And so you have to be much more refined in your movements. And so unless you're very, very comfortable using a two-dimensional endoscope, a three-dimensional technique such as a microscope might be better for you. You also have a limited space to move around. You have to use a holder. The light source can produce heat, so you have to be very cognizant of that when you have an endoscope in the back of the head, that you're not burning anything. And right now, it is not as far along as it is with the nose. And so some of the instruments that we have are still limiting our ability to do some of the things that we'd like to be able to do. For example, sometimes there are tumors that we can see, but we don't have instruments that can reach them yet. We've been using the endoscope now for trigeminal neuralgia for about the past 7 years. And for those that don't know what trigeminal neuralgia is, it is a horrible face pain syndrome. In the old days, it used to be called tic-douloureux. In the 1800s, it was one of the most common causes for people to commit suicide. The pain is horrible. It's worse than childbirth or anything you can describe. It's a stabbing, electrical shooting pain that will stop people in mid-sentence. They can't eat, they lose weight. It is miserable. And the cause of trigeminal neuralgia is due to a blood vessel pressing on what's called the trigeminal nerve, which is the fifth nerve coming out of the brainstem. And there's an area on that nerve where they don't have very good insulation. The myelin is a little bit deficient. And so if you have a patient with deficient myelin who has a blood vessel pressing in that right specific area, right where the nerve comes out of the brainstem, they will develop trigeminal neuralgia. In our series, we've seen 243 patients that we've evaluated for endoscopic evaluation. 191 of those we actually thought, yes, you probably have trigeminal neuralgia and you should have something done for it. There are two different types. There's what's called type 1 and type 2, or what we call typical or atypical trigeminal neuralgia. The type 1s are the ones where you're pretty confident you're going to find something pressing on the nerve. The type 2s are people that have some symptoms that don't quite make much sense, and you're not 100% sure if this is truly trigeminal neuralgia or not. In our series, 154 of them have never had any kind of treatment for this. 9 of them had had previous surgery for it, and 28 of them actually had what's called gamma knife for it, without obvious success. In our series, we did 108 of them purely endoscopic. We did 83 of them with what we call endoscope assisted, meaning we did the exposure with a microscope, and then once we got in there, we used the endoscope to look around to make sure we identified all the blood vessels compressing the nerve, and then did the decompression with the endoscope. On average, these patients are in the hospital between 2 to 3 days, and we've had no major complications in the past 7 years doing it with an endoscope. So here's a video of what the surgery looks like. I'm going to scroll through it just for time constraints, but again, this is our opening. It's about 1 inch. This is one of our very first cases, so this is during the learning curve. This is before we had an endoscope holder. So I was holding the endoscope and I was doing the procedure as well, and you can see it's very difficult to do it that way. So here we have a little retractor. We're retracting on the cerebellum a little bit. We start to see this little vein here, which is the petrosal venous complex. Some people call it Dandy's vein after Walter Dandy, who described this problem. And then here we see the 7th and 8th cranial nerve. Here's the brainstem. This is the trigeminal nerve, and you see there's this blood vessel that's just pressing on that nerve. It's banging on that nerve, and that's the superior cerebellar artery. That's what's causing this patient's pain. And all we basically have to do is move that blood vessel away, put a little piece of felt, like a little sponge, between that blood vessel and that nerve, and the pain goes away in a very high percentage of these patients. So here we are putting a piece of felt in. I usually put lots of pieces of felt in. There are different techniques. Some people put just one large piece. I use lots of smaller pieces to help conform it a little bit better. But essentially that's what we're doing. And you can see I'm using one hand to use the instrument and one hand to hold the endoscope, so it's not optimal, but it worked. The amazing thing is if you look at the anatomy, we're looking along the entire course of the nerve. We're seeing all the way out into Meckel's cave. We're seeing all the way up into the pores acousticus for the vestibulocochlear complex. We're seeing the brainstem very clearly. There's no question here what's causing the problem. So when we looked at our data of patients that we treated with trigeminal neuralgia using an endoscope, and those who had never had any previous surgery, 92% of them woke up from surgery pain-free.